So I have a little bit of unique practice in that my practice is spine and trauma. I still do a lot of complex pelvis, acetabulum work. And so I end up actually fixing a lot of these pelvis fractures that require spinal pelvic fixation. In fact, most of them. So I do a lot of work around the pelvis and not just from a spine standpoint. Uh-oh, did we battery die maybe?
Wait, can I get a video? Can someone just save that video clip for me? I just want the soundtrack for that. You think about what you just said.
All right, so we're going to talk about some different examples, and some of it's percutaneous, some of it's not, but I think when we think about sacral insufficiency fractures, some of this can occur below instrumentation or it can occur primarily. A lot of sacral insufficiency fractures can be treated non-operatively. There is an argument for sacroplasty, cement augmentation. I'm going to give you my thoughts on that and a little bit of the data. And then percutaneous spinal pelvic fixation, I'm going to show you some examples of that. So this is just a patient with fracture below the instrumentation, showing you these can be treated non-operatively depending on the circumstances. This is our initial post-op. This is one of our classic osteoporotic big ladies who you can see we put some lateral inner body, so we actually corrected her lordosis a fair amount. Now, if I correct lordosis, even if I'm doing 2 or 3 levels, if I make a substantial change, I actually fix to the pelvis right off the bat. This patient is 2 weeks out and did okay initially, then came in with a significant increase in pain. If you look, I'll get the pointer in a second, but if you look carefully right there, you have something happening. You have to look at your x-rays carefully. You almost have to look for these things because you'll miss them. And if you look on a CT scan done to evaluate, you can see the fracture right below the S1 pedicles. 3 months later, non-operative treatment, pain resolved. And I think the key here is that it's not kyphotic. If you get kyphosis in the sacrum, it significantly impacts your overall alignment and lordosis. That's the one thing. That's the one thing that can change pelvic incidence. So what happens is if they're kyphotic, their pelvic incidence changes. And I'll show you an example of that. They become very hyperlordotic in response to that. So you do want to correct kyphotic alignment. You don't have to correct translational alignment. And they can heal. So I think if it's severely kyphotic, it's a different circumstance. 3 months later, pain resolved. This one did well. This is different. This is the same kind of circumstances. This is a 75-year-old, another somewhat obese female. You can see has a little bit of sagittal plane issue, severe stenosis, mobile listhesis at 3-4 and 4-5. So we corrected her. This is what my patients look like. You can imagine trying to see the cervical-thoracic junction. We've never seen one, so I don't know if you can see that on an x-ray. But this patient, this patient, about a month out, had an increase in pain. You can see this one has is having, when they stand, a significant kyphotic deformity and also had urinary retention. This is going to force you into the operative mode. The kyphosis, perhaps, probably, certainly in a young patient, but also her urinary retention. She was brought to the OR and we decompressed her. We did dual iliac crest fixation. We tried to correct the kyphosis somewhat and decompressed her bladder bow. We don't worry about translation. So most papers on this and treating these adjacent fractures non-operatively support non-operative treatment. Some fail, and those are the ones that have to go to surgery. I think it's similar to any insufficiency fracture. The ones that you can mobilize, keep going, don't have neurological issues, not severe kyphosis, you can follow. As long as they mobilize, the pain does tend to resolve. In those people who have neurological issues, severe kyphosis, progression of the kyphosis, won't mobilize, those are the patients you have to do. And these really can't be done percutaneously. So for unstable kyphotic fractures, there are almost always delays in diagnosis because people, when they're having increased pain, don't look there. This is another group that looked at 6 papers reporting on just a few cases, typical delay in diagnosis. Most respond to non-operative treatment. But when you have to fix them, you have to extend them down to the ilium. And I often use dual screws when I do that because they're bones osteoporotic. You can't get fixation in S1, so you need to get good fixation. So I end up using 2 rods, sometimes a quad rod situation. But that's an open surgery when that happens, okay? So sacral fractures below the fusion have a very long lever arm. Typically, they're usually not 1 and 2 level fusions. It's really high mechanical stress. They can be treated non-operatively, but when operative treatment's necessary, you have to open these. These can't really be done percutaneously. And non-operative should succeed in even a larger percentage without instrumentation. Primary, oh, great, thanks. Okay, so is there a role for sacroplasty in these or other just primary sacral insufficiency fractures? So I'm going to talk more about primary fractures now. This is a shear injury. This is not an injury in compression. And we heard about pulling out the screws. Cement is not good in torsion. It has no strength in torsion. And these are shear injuries. Cement, it doesn't protect motion on shear. It resists compression. These are shear injuries. Essentially, what's happened here is it's still not working. What's happened here is that the forces are this way, are breaking the spine free from the pelvis. Okay, it's an axial load shear injury. It's not a compression injury. They're not compression fractures. And you can see how the forces go, forcing it into kyphosis. Oh, okay. Oh, yeah, you had to be a little smarter than I was to work this thing. You had to be an IT guy. So cement resists axial load. It's not good in shear. We know that that's not going to work in a high energy fracture. So why would it work in a low energy fracture? Like how does it make any sense at all to work in a low energy fracture? You know, if you look at this, you can see even in this high energy young patient that we fixed with spinal pelvic fixation and a transiliac transsacral screw, you can see the force is putting a bend on that screw. It's a direct force. Their weight is pushing down. It's almost like a sling. And we see this not infrequently. So can sacroplasty work? It doesn't make sense to me mechanically. So a lot of these are radiology papers. So the indications are not real clear. A lot of them are unilateral sacral insufficiency fractures as opposed to sacral U's. Sacral U's, it makes no sense. Even unilateral ones are also shear fractures. They're not axial load fractures. And so there are papers. This is a review of sacroplasty. This was 2009, no level 1 or level 3 evidence. This had 108 patients they looked at. And, you know, they didn't even document the pain improvement. So they said, where documented, there appeared to be a significant improvement in pain, and they suggested that this can be effective. There's no timelines. This is not a particularly well-done paper because these are just patients who had a radiographic finding that somebody did a procedure on. This is the problem, again, I have a little bit with kyphoplasty on who does it. They clearly are capable of doing it, but who is selecting these patients, following them to determine? It's not clear. This is also from 2009, another review of the literature. You can see the technique for cement, same paper. They didn't include fractures after lumbar instruments, mostly done by radiologists. Sacral insufficiency fractures at a single center with 185 patients, 5-year follow-up. They had 102 treated non-operatively, 83 sacroplasty. These were not randomized. And they did feel like the sacroplasty patients had improvement. But interesting, if you look at them, the conservatively treated patients had a much lower visual analog scale pre-op than the sacroplasty, and they probably selected them based on that. If you look at the improvement after the sacroplasty, it was 3 points here and it was 3 points here. They're on different places of the scale. This clearly has a significant floor effect. It can't get much less than that. Whereas the sacroplasty here, as the fracture healed, the pain can improve and get basically back into the range with conservative treatment because there's a floor effect. Okay, so just like we saw a ceiling effect, you can only get so good. You can't get much better than that. And that's with non-operative treatment. So I'm not sure this demonstrates that it works, but that was the data to support it. Uh-oh, what did I do? Okay, oh yeah, here we go, we're back. All right, so I doubt that success is from mechanical stability. There's no way, it makes no sense. It can't correct kyphosis that exists. So if it's kyphotic, it's not an option. It's only for non-displaced fractures with persistent pain, and it may be the cautery of nociceptive fibers, pain fibers, that gives them the pain relief. That's the only thing I think that could benefit, because there are papers to suggest a benefit. So what are the indications then for percutaneous fixation in primary fractures? If a lot of them we can treat non-operatively, if they mobilize, if they're not kyphotic, they have no deficit, a trial of non-operative treatment is worthwhile and most improved. It's the patients with cauda equina syndrome, okay? Obviously sacroplasty can't correct that. It needs to be decompressed and stabilized. The data on our ability to prove neurological function after this, so-so. Okay, so often it's bladder issues. These are below motor function. They may get some dysesthesias in their legs from the S2 if they affect the S1 route, but it's mostly bladder bowel issues. You can stabilize these percutaneously. You can even correct the kyphosis percutaneously. And if you need to do additional decompression, that can be done with a laminectomy. If there's a hump, you don't necessarily have to correct the hump. You can take a tamp under the nerves and just smash that hump down in the front so that it smooths off, okay? The other reason is persistent pain, poor mobilization. Not necessarily worsening radiographic features, but pain that doesn't allow them to mobilize. The problem with this indication is that many of those patients aren't mobilizing because their pain threshold's not as good as the next patient. So we all have patients that complain of pain more, don't mobilize when they're painful. You do have to wonder if you improve the pain, how much good are you going to do that patient? So pain's more complex than just the x-ray, but these are often the patients who we consider doing it. This is an example. This is persistent buttock, low lumbar pain. It can be unilateral. The vast majority of these resolve in 6 to 12 weeks. You mobilize them with a walker. I let them all weight bearers tolerated. This is different than high energy sacral U's or pelvis fractures. Treat their osteoporosis. Remember to always look at the T1 image. This is where you're going to see it. On T2 imaging, you can miss it. You can see it on a stir, but it's hard to see on a T2. Always look at the T1. Make sure you go all the way to the bottom of your MRIs to find this. A CT scan really is what helps you define it. You can see bilateral fracture sacral U. This patient didn't get better. Okay, so most of these don't require reduction. This one did not. It just needs stabilization. In that case, if I'm not reducing it, I could just put bilateral perc screws in 5. I can use a teardrop view and put my iliac screw and put my rod in percutaneously. I specifically don't put a screw in S1, so I can get 3 points of fixation in different directions. And I put my transiliac screw into S1. That allows me 3 different points of fixation in all directions, and it gives me room for that. All that's percutaneously. If you need to reduce it, and you can see this one has severe kyphosis, which I want to correct, and cauda equina compression. I can probably affect the cauda equina just by reducing the fracture. If I need to, I can do a laminectomy. I can knock in the posterior wall around the corner. So we reduce these percutaneously by putting them on a Trios or Jackson bed. Sometimes I actually put extra blankets under their thigh to hyperextend their hips. When I hyperextend their hips, I can bring this part of the pelvis into extension to match that part, just like reducing any fracture. So this often corrects it if you're doing them early. It's hard to get that to work if you're a few weeks into it. I sometimes, and you can see I did it here, I have a Chance pin in the ilium above where I'm going to put my iliac screw. I put a Chance pin in. I put them on both sides of the pelvis because the pelvis is attached, the iliac wings are attached to this piece. This doesn't have iliac wing attachment. So I'll put Chance pins into both iliac wings. I'll actually connect a carbon fiber, nice long bar to my Chance pin, and then I'll use those as levers to lever the pelvis up percutaneously. In osteoporotic ones, again, that's going to be limited based on their bone. It may plow through the bone. In younger patients, you can just lever them up. If that's still not effective, then I'll make a small laminectomy. I'll wedge a cob into here, and I'll use the cob to pry against the bone to push it up through a very small window. And then you can get a reduction. You can see the reduction here is pretty darn good. It's hard to get it perfect, but the kyphosis is reduced. If I had to open it, I can also tamp that bone down a little bit, fully decompress them. If I'm reducing them, I put screws at L4 also. So I have a little more point of fixation. And this is what it looks like. So this one, if your anatomy's not favorable for a transiliac transsacral screw, then I'll do bilateral iliosacral screws. So this one, no favorable anatomy for a transiliac screw. This one got bilateral screws. So in summary, so we're seeing more and more of these. Patients are getting older, same thing. We're seeing everything in osteoporotic patients. We're seeing tons of these. It can be unilateral, but quite often if you look, it's actually a sacral U fracture. It's often not just a unilateral fracture. Most can be treated non-operatively, and I would always use this as long as the patient can mobilize it and is neuro intact. Okay, I'm not sure why sacroplasty would work. It doesn't make good sense to me. I have dealt with failures of this. So the radiologists do it, they think it works, but they don't follow the patient at all. So I've been told by them this works, but then I see the patient hasn't worked. But clearly in the literature, there are patients that benefit. I don't see the ones that got better. So I don't know how many they do that get better. And when necessary, percutaneous screws in 3-point fixation with a transiliac transsacral or bilateral iliosacral screws are the way to go. Percutaneous fixation here works pretty well. It's actually relatively easy. When I first started doing it, it seemed like it would be really hard to connect the rods. It's really not that hard.
Great stuff. Thank you. So instead of me giving a lecture, I'll ask our fellow Dr. Davis, he's also known as D3, to present a case, and then we'll have a discussion on some of the highlights. I'll just fire some highlight questions at you all. Maybe you can sit on the front tables, chairs. Right now you can sit here whilst he shows this case. And we will then do some highlights, and then maybe you'll, John, because you're the horse-working guy who gives, you give the grand finale talk on high-tech for trauma. All right. Would that be okay? And I'm gonna forego my lecture so we can finish on time or with the gift of premature finishing.
All right.
Briefcase. D3.
All right. This patient.
I'll just give the context.
Thank you.
Putting everything together that we've just seen and so many more things. Osteoporotic fractures, fracture ratings, stuff like that.
Yes, sir. So this patient was an 80-year-old, very active man with a burst fracture treated with a kyphoplasty at an outside facility and previous underlying diagnosis of osteoporosis. And these were his presenting x-rays on the left and the post-kyphoplasty images on the right.
So Dr. Schnake has gone to bed. Dr. Harrop, you've been unusually quiet for a while. Does this German classification system help? Does this, Dr. Schnake?
I just got back from the bathroom after listening to John's talk.
Dr. Schnake showed a German classification system for osteoporotic burst fractures. Does that help in the severity rating? We don't have Dr. Schonert here.
Does it? I don't know. It doesn't help me. I
Yeah.
mean, I look at this guy's MRI and I kind of look, actually,
Dr. Treadway, you're usually not shy of controversial statements. I'll give you, John, would that help you? Was this a good use of cement?
This was a very bad use of cement. But if the patient's pain is better, I understand why they use it. But from a surgical standpoint, it's not going to be very helpful. It's going to be kind of a pain in the back.
I think the classification system does make some sense, but it does not have the timeline of evolution. It does not talk about what this guy has, which is a pretty bad
Neurogenic claudication.
neurogenic claudication. So the cement may or may not have helped his pain in one regard, but now he has significant activity restrictions, and this is a extremely high-functioning 80-year-old with means.
There we go.
well, go back to the original one because now he has a burst
He's
fracture,
not our
right?
patient. He was not our patient at the
It
time.
was a burst in the beginning.
Oh, was it a burst in the beginning?
This was treated at outside facility.
What do you think this was in the beginning? If you saw the presentation by Dr. Schnake earlier, so first of all, standard AO classification would be
AO3.
A3, and then this osteoporosis, this OF score, 3-ish, 4, something in the middle. I can't remember it totally, but yeah. And the cement leakage, by the way, having been burned on cement leakage before, medical legally speaking, there's clear leakage here. So 25% is an underestimate. I tell Neil that all the time. It's like 80%. Depends on how close.
100% agree with that.
Yeah. So 80% plus. Here we have a nice vascular gram, but tolerated well. So cementing did exactly
If anything, it exacerbated its stenosis.
made it worse. Okay, so now we have a mess. We have stenosis. Again, assume that this, despite being an octogenarian, extremely functional person with a very active lifestyle, is now quite unhappy. Who wants to take this on? Any takers? News, you've been also highly quiet
Can
for
I ask
a while.
a really dumb question?
Please, fire away.
What's going on with his bone marrow seems very unusual to me. Is this guy radiated or something? He's got fatty infiltrate. I mean, the guy's got great muscles and everything, but look at him. He's got fatty infiltrate all through his facets, posterior margins. He has no bone marrow anywhere. Like, does he have a history of having?
Did you do the HU units on him? I think
No,
it was in the
this isn't
70s.
osteoporosis.
This is fatty substitution. This is senile osteoporosis.
Yeah.
He actually got a workup for systemic or marrow disease.
Yeah.
He has senile osteoporosis, but again, the brain is working phenomenally, and other parts of his body are
muscles
working
are
well.
fantastic. They're probably
Yep.
better than mine.
But he is basically, I thought it was 60s or 70s that his bone structure was. I
That's
measured
what
it.
it looks like, just
Yeah,
eyeballing.
it was terrible.
I mean, I think, though, when you want to look at the marrow, I mean, it is fatty-looking marrow. That's osteoporosis. You got to look at the T1 image for cellular replacement. The marrow actually appears darker. I don't think it would on this case. Some older patients, just because they're anemic, get a very heterogeneous marrow because they're having a lot of cellular turnover. But I think if you're considering things like myeloma, you have to look on the T1 image.
Fair point.
Yeah, there was no curveball in terms of a hidden neoplasia, but the points are very well taken, especially in that age category.
Thank you.
So what to do now?
So then,
Pause thoughts.
Pause
So here
thoughts.
we have a patient who has significant neurogenic claudication. And if you go back 2 slides to the clinical presentation, so the patient had walking difficulties, and he presented to me, and I told him, yes, you might benefit from a decompression. If we're talking about decompression, I want to avoid a fusion. Let's ask Dr. Daly, any thoughts on what you would offer this man if you pass the microphone along? So he has neurogenic claudication.
He says absolutely no to a fusion at this juncture.
Well, he would take whatever you want to give
Then I
him.
would absolutely encourage him to have a fusion.
From where to where?
So I would go at least T12 down to L4 and, grab 2 above, 2 below, and do bilateral laminophoraminotomies to try to open up his canal, and then also try to do a transpedicular sort of push of that fragment ventrally.
Ventral disimpaction.
Yeah.
Wow. Did you?
I'll throw it out this. He should be in prison for that comment, number one.
No problem, Jim. We have stouter patients than you do.
I mean, it's the guy's got neurogenic. To me, I'd give the guy an epidural steroid injection.
He's actually had that, and he's had a brace. I gave him a brace. I put him
But
on.
why? I mean, why are you stabilizing a guy from T12 to the pelvis for?
Well,
How much back pain does he have?
I forgot. What do you gather from the records? I mean,
I
he
think
has back pain.
it was mentioned that he had back pain, but his main symptom was
So what's
neurogenic
worse? Is it
claudication.
leg pain or back pain?
So it's primarily neurogenic claudication in the legs, but
So here's my humble opinion. So as tempted as I am to do a prone lateral corpectomy here of L2,
Are you guys going to be in prison together?
I said as tempted as I am. I would internally choose against it, and I think that you could achieve a minimally invasive decompression here through a tube or whatever your decompression of choice is, and you could relieve his neurogenic claudication. You may actually relieve his back pain as well.
Hallelujah. This is exactly what I suggested. Midline sparing, hemileminotomies, decompression, some ventral disimpaction. He has cement in the front for whatever reasons. I'd probably even do a discectomy, upper end plate resection. That's exactly what I said.
So I think we have to distinguish where the fractures are. So at the thoracolumbar junction, these tend to go into kyphosis, and the neural elements can't move away from the anterior disease. And they kyphose more. The further you get into the lumbar spine, mechanically, the forces are more into the facets. This is why low lumbar fractures don't always kyphose. They go down flat because the forces are posteriorly. So if you're going to address an osteoporotic fracture and you're going to, say, decompress this situation, I would rather have it be like at L4 and go 3 to 4. But when you're in that lordotic segment, the stresses on your hardware are not the same as if it's in the thoracolumbar junction where the forces are going into kyphosis. It's a whole different mechanical situation. So I think if you're going to do it, I probably would be very nervous. I don't think you need to tamp the fragment for it. I think when you do the laminectomy, it'll fall away enough that you won't have an issue. But I would be very worried that I would affect the mechanics with my laminectomy because it's an incremental destabilization. I probably would put screws into one. I would drill the cement and tap it and just put a screw in that cement. And they already put cement in 2, and then I would put a cemented screw in 3, and I would probably just do a screw above and below, so I would support my decompression. But I don't think you need to tamp the fragment forward.
So as someone who has been trained in minimally invasive spine surgery and someone who is going to have his fellowship revoked today, I'd be very careful doing a minimally invasive decompression on this because now you're going to compromise the third column. And that's what we've kind of been talking about earlier. I think that this is a dangerous one. You could try it, but look at the facets. It's kind of going through there. There's a little bit of fluid in the facets. It looked like I thought. And so I'm afraid if you do a posterior decompression, you're going to get a pretty bad kyphosis. Now, I do like ATD. I don't really want to go to jail with him, but doing a decompression and instrumenting at T12 down to L3, maybe 4, isn't the worst idea.
It's not bad because then you get the next operation when you get your junctional level of breakdown.
Well, we get 10 years and we'll be coming back. So
10 years, you got about 2 weeks. So let's go back and go through this like logically. So the guy comes in, he's got osteoporosis is his first problem. So I would probably treat him for his osteoporosis. So a couple of things about compression fractures. 2/3 of them people are asymptomatic, 1/3 are symptomatic. 30% of them get another fracture within a year if untreated. Framingham study, another paper you haven't read, but we'll go through that later. Now, the second issues with him, according to everything I've heard from him, this wasn't a trauma. The guy had a fracture that was picked up, but he's presenting for neurogenic claudication, which is, the last time I checked, is not a stability issue. It's a stenosis issue. So you can go in there, take the facet off, and tap the bone down, or you could open up the canal. Now, I would probably say, I'm going to treat you for your osteoporosis. I'm going to ignore you like a good doctor, like you do with your facet fractures. Yeah. I'm going to put him into physical therapy or whatever, and I'm going to give him 3 months for him to heal. So now your stability issue's resolved because his fracture's healed, and then I would do a laminectomy. And I wouldn't do the minimally invasive thing because by the time you guys are setting up with all your freaking machines beeping and everything like that, the patient's in the recovery room if you do it open.
So you do a full laminectomy? You said full
laminectomy. I would do it L3. And if you want to be, okay, I'm really nervous, you could do a hemi-laminectomy and go to the other side.
Give you axial MRI through the stenotic segment.
The MRI's been running continuously for the last 20 minutes.
No, I know, but I wanted to make a point.
You got to be really fast.
If your stenosis is all out in the lateral recesses and at the midline cut, there's plenty of room, then doing like bilateral laminotomies can work. But if the stenosis is at the midpoint of this canal, I'm very leery of that work. And you can do an over the top if you want to do a minimally invasive decompression. I suppose you could go over the top, but to me, this one isn't real favorable for one of the midline sparing approaches. I would agree. If I'm going to decompress it, I'm going to decompress it. I'd be worried it'll kyphos over if I do that, though.
Fair enough.
Here's the thing, he's 80 years old.
So what do you think the chance? This is what I always talk to my patients. I'm like, what do you think the chance
Microphone,
of this guy's going to
microphone.
kyphos over?
We still have,
Give me a
like-
percentile.
Microphone.
20%.
Oh, sorry. So what do you think the chances this guy's going to, 20%? So I go to my patients, I go, listen, I can do a fusion on you, which is a longer operation,
Yeah, it's
and you have a higher morbidity, and you have a higher risk of an infection, and you have a higher risk of junctional breakdown for a 20% chance. Or we can do the laminectomy, and then you kyphos, and I do that operation next.
Okay, we
The-
can't.
the problem is if he
we're
kyphos-
kind of spinning our wheels here. I'm going to ask our colleague from San Diego, put some clarity in this. Highly functional 80-year-old, you heard the whole story. Stenosis is a problem now, had failed vertebroplasties, kyphoplasties, whatever you want to call that now.
John, if you said blue, I'd say red.
I would probably try the minimally invasive decompression and see how he does.
Yes.
Excellent.
Give it a shot.
Let's poll other colleagues. Harborview.
I think a de-
Go MIS.
T3 to pelvis. Yes, say it. You can say it.
part of me wants to just side with Dr. France's opinion on everything, but I think a decompression, we would just do it open, but not instrumented, just a decompression.
Decompression. He looks at me questioningly. Our colleague from future Nebraska. What are your thoughts? You've been a voice of reason all day long.
I'm going to do an open laminectomy for this guy, but I am going to do a fusion for him. And hospital wants to get paid, so we're going to go T12 to L3.
Are you gonna use a little cement blobs like what Dr. Schnake showed?
Probably. If I
Okay.
can get my hands on the little.
Okay.
You might as well throw B&P in there. While
We,
we're throwing money at
a
you.
man who's been quiet most of the day, Cliff Pierre. So you're always very measured also. What makes most sense to you now if you take a big picture perspective?
I think big picture, you can always do more. So I agree with Dr. Harrop. I'd just do a
There we are. This is the
decompression.
voice of reason. Finally, at least I got through to one person.
Because you could always do more later if they collapse, put them on treatment.
All right, take us forward. So he came to me. I had actually suggested midline sparing hemilaminotomies, microscopic. I don't do all that tube stuff anymore. And he went to a different surgeon, and he had what done?
He had a midline sacrificing laminectomy.
Full laminectomy. And how did that go?
He received a midline sacrificing laminectomy at outside hospital. He got infected. He had a collapse, a pulmonary embolism, necrosis of his L2 vertebra surrounding.
Other than that,
He's great.
how long was he in the hospital for this outpatient procedure?
Oh, I don't remember exactly how long, but
A couple of months.
A long time.
Yeah, a couple of months.
A long time.
And then rehab, not to forget.
Yeah.
So that worked well, right? So he's back to the brace, and now he's coming back, and he's a full laminectomy done.
See, this is the problem. It would have been much easier to prevent the kyphosis with short segments than it is to correct it. Because to correct it now, I think you are going to have to go up to 12, and you're going to have to go down to 4 and be in jail with Andrew.
So wait, the guy had the littlest operation possible and saw God. So now we're going to say if we did a bigger operation,
I would
he
probably
probably wouldn't have died.
I would
With an
probably tell him to
infection.
do
With an
nothing.
infection.
But I'm
Because-
saying
And it's anticoagulated.
Because we know that when you do a decompression only, your chances are lower than when you put instrumentation in.
I'm not saying I would do that, but I'm saying if something had to be done, I would try to convince him to do nothing.
Let's ask our German surgeon, Dr. Lewitz, who's going to do his best to impersonate Dr. Schnake, who had to sign off because it's only like 2 in the morning there right now. So what is Dr. Schnake going to say? What are the Germans going to do with their wizardry and the endoscopes and everything?
Perfectly lined out. It's actually kind of nice.
That's because he's laying down.
Yeah. Okay. Hard to tell what Dr. Schnake would say on it. Yeah, I think I have to admit, like from my perspective, from the trauma clinic that I actually work in Germany, we would have also done more like an open procedure and a laminectomy as well. I think. Yeah. it's easier to see it like from the retrospective view how it all ended. But yeah.
So are we heading towards a fusion now, or are we going to tell him this is it and G-D talk to you and this is not meant for you? James, are you saying no more?
Here's the question. I mean,
Microphone.
So here's the question. Now you got a different problem. So first of all, I want to make sure the guy's not infected in his cement and his disc space, which you no longer can see. And then I'm thinking he's going to get a lot of medical doctors to see him because I'm probably going to kill him. But now you want to use your percutaneous operation. I would probably do perc screws in the back and do a thoracotomy and take out the cement infected and put a graft in the front.
What percentage of your patients do you normally kill, Jim?
This is so it's interesting you say that, because I think that this now is the indication for it, for the prone lateral, because you can address the anterior column, you can get all of that stuff out, you can push the fragment either in or out.
Fragment's a problem. He's decompressed.
Right, exactly, and you can fix, and you can choose how high you go. I think that you're forced to go at or above the junction now, and I feel bad. He's 80. And also, the infection, could that have contributed to this as well?
By the way, when I've done exactly 3 patients, and so this is not anything meaningful. But I've done these osteoporotic burst fractures with a cementing. I've done decompressions. I've put a off-label interspinous process spacer called C-O whatever in there and held it, and they've actually worked. So I've maintained the posterior column and. But that's off-label. This is not a durable series, but these are the honest-to-God follow-ups on 3 patients. I followed them very carefully. So we have a mess now. So take us forwards.
Yes.
So he was very, very unhappy. And so I went for surgery. And I did what Dr. Schnake and everybody said we shouldn't do. We did a relatively, how do you want to paraphrase what we did here?
Yes, so we did a long fusion with cementing UIV +1 and LIV -1.
So one level below, 2 above, and we did a UIV +1, LIV -1 cementing. So when I saw Dr. Schnake's images on his osteoporosis patients, I was amazed that he didn't put any cement above or below. I mean, in my hands, they blow apart immediately right there. You showed a patient very similar to that. So he didn't do that. I was very curious about that. But we actually did a full corpectomy, and we didn't find any infection. We're prepared for that. And we, can you show, do you have the coronal CT? We did, what did we do about the cages to save a nerve root? Dr. Franz showed a beautiful costotransectomy.
I didn't have a coronal slices, I'm sorry.
Show the axials again.
Did you do it all from the back?
I did it all from the back. So I did dual cages. I did dual cages, and I've done that a number of times now, where I use cervical expandable cages with the largest possible footprint. I put the rings on the apophysis, so it's not in the center of the vertebral depression. Just like what you said, I tried to put a cement blob on there, but I didn't get cement on the top. But the 2 cages have actually worked quite well. I think we have like 8 patients or so now with dual cages. Alan Daniels wrote up 2 patients, so maybe Neil or D3 or Brian we'll do a brief case series, but they've actually, so how did he do from this?
He did well.
We have a final post-op film from him, like from a year out.
This is what I've got.
He came from Austin.
I apologize.
Can I get out of jail now?
Yes.
No. Right
Comment.
No, he showed the 1% complication on a guy, and you guys want to do it on everyone.
This was a setup.
Yeah, but he showed the 1% complication. Dude, my infection rate's 1%. So the 99 other people got away free.
My question was just, you had mentioned that you were prepared for infection, and I was hoping you kind of expanded on that, what you meant.
So great question. So this patient had a significant infection, so we obviously dissected. We took off soft tissue samples. When we did the corpectomy, we did exactly what I think Nuj hinted at. We took the cement out. We sent it off for microbiology. We had a pathologist come in and basically do micro slices to look at any colonized kind of structures. We then, I think, washed them out with 9 liters. We used a thoracoscopy irrigator and irrigate out that inner space so it's completely debrided from both sides. So there's a through-and-through washout. We did literally a costotransectomy, nerve root sparing, and I, at that point in time, then felt convinced that we had a clean field. We did not put any hardware or cement in until we had this field as cleaned and washed out as possible. Had there been an infection, I would have, to preempt your next question, I would have put in a temporary fixation with small rods and probably a PMMA block in the front, and asked my miraculous colleague, Dr. Oskulian, to fish that out later with a far lateral approach and put a large bore cage in through a far lateral approach. That was my, and the PMMA spacer would have been a combo of Tobra and Vanco. And in our own osteomyelitis series, and I think Dr. Plumer has a very nice, incredibly large series of whatever, 80 patients or so, these PMMA spacers have worked beautifully. Many have not even had to be removed. They serve as an extremely strong antibiotic local delivery system. That's a whole new talk for a different session, but they work in very high doses, about systemic doses, for about 2 to 3 weeks, and then overall for probably about 6 weeks there's an antibiotic elution there, and it converts a dirty field into a clean one. But we exactly thought what Nu said, this weird collapse that he's had is a highly suspicious situation for an infection in there.
And he did say laminectomy.
We did it all from the back at this point. Yes, yes.
Yeah, I think if you do it from the back, you can't put a large cage in and preserve the roots. I mean, I've never been able to get it in, but these small cervical cages, I often use just a mesh cage, and I do that a lot for like discitis at 5-1 or 4-5 because I don't want to go in with iliac vessels, or if I have to do like a 5 corpectomy for infection. And you can take the cylindrical cage, put it in this way, and then roll it up, and then jack it open. You can put one from each side. And so I use 2 cages under that circumstance a lot because you can get them in. You can get these in, but you can't get a big one in.
That's exactly.
And preserve the roots. For those, I use mesh cages. I think it could be either way. The expandable cages would be a little easier because once you get it in, because you have to put the mesh cage in, you have to distract, get it in, and then compress down on it or to make it stable. This, you could make it stable by just expanding it.
Yep. I can pull up the final images shortly. He was very happy with this, actually, and he's had his 1-year follow-up, and he came by. He was very grateful, so that was kind of cool. But yeah, this was a difficult case. The frustrations of osteoporosis care, I think, shown through in every single regard here, and just doing a wide laminectomy is not a good thing because they do lose their last check rein.
I'm pulling up the finals.
That's okay, yeah. So let's finish up. Dr. France has one more lecture. I'm going to forego mine.